Welcome to the deep dive. Today we're getting into a really complex topic, disseminated intravascular coagulation, DIC for short.
Yeah, it's quite something. Imagine the body's clotting system, which is normally so carefully balanced, just going haywire.
Haywire how? Like
Yeah.
accelerating and braking simultaneously?
Exactly like that. It's a perfect storm within the bloodstream, really shows how delicate that balance is.
And you mentioned before we started, it's never the root cause itself.
Never. That's key. DIC is always a complication, a secondary response to something else major happening in the body.
Got it.
Essentially, the clotting system gets massively activated everywhere systemically. And paradoxically, that leads to both forming too many clots and a serious risk of bleeding out.
Right, like trying to patch a leak by turning on all the fire hoses. So for this deep dive, we're working from some pretty focused revision notes on DIC. And the plan is to pull out the really essential high-yield stuff you need to know to, well, understand it properly.
Yeah, hitting the key points, making it stick. We'll try and cover the definition, pauses, how it works, how it looks, tests, management, the whole picture.
And maybe some memory tricks if we can find them.
Yeah.
Okay, let's dive in. How do we formally define DIC?
Okay, so the official definition from the ISTH, that's the International Society on Thrombosis and Hemostasis,
Right.
they describe it as a systemic activation of blood coagulation, so widespread clotting activation.
Systemic meaning all over.
All over. And this leads to fibrin being generated inside the blood vessels. Fibrin makes clots, so you get vessel thrombosis blockages, and ultimately organ dysfunction because the blood supply is compromised.
Oh.
What's really central is this inappropriate, massive activation of thrombin, a key clotting enzyme, and also plasmin, which is part of the system that breaks down clots.
So both the clot-making and clot-breaking systems are in overdrive.
Exactly. And that can manifest either as loads of tiny clots blocking small vessels or as really significant uncontrolled bleeding, or sometimes both. And it's really important to stress, acute DIC is a very serious sign. It massively increases mortality risk from whatever underlying illness actually triggered it.
Got it. Always secondary, potentially very dangerous. So what are these underlying triggers? What sort of things can actually kick off this cascade?
There's quite a range, actually. A useful mnemonic, sometimes mentioned, is STUMPLOTS. It helps cover the main categories.
STUMPLOTS. Okay, let's hear it.
So S is for sepsis and severe infections, probably the biggest triggers we see.
Okay, sepsis.
T is for trauma, particularly major tissue injury like severe burns or crush injury. O is for obstetric complications, things like placental abruption, where the placenta detaches early, or septic abortion.
Obstetric.
M is, or for malignancies, especially cancers that have spread widely, metastasized. Certain leukemias are also strongly associated.
Malignancy, okay.
Then S for snake bites or other venomous envenomations. Some venoms directly activate clotting.
Snake bites.
L is for liver disease, particularly severe liver failure, as the liver makes many clotting factors.
Liver disease.
O, sometimes thought of as overlooked transfusion reactions, like giving incompatible blood.
Ah, transfusion reactions.
And the final T is for therapies. Certain medications or treatments can, in some cases, contribute.
So, STOMPLOT, sepsis, trauma, obstetric, malignancy, snakebite, liver, overlooked transfusion, therapies. That's actually really helpful.
It covers a lot of the common ground, yeah.
Now, thinking about risk factors, do they just mirror these causes, or are there other things that make someone more susceptible if they, say, get sepsis?
They do overlap a lot, as you'd expect. You can think about general risk factors like being older, having other underlying health conditions that might predispose you to one of those triggers.
Right.
But then more specifically, yes, it comes back to those conditions. Severe sepsis, major trauma or surgery, cancers like leukemias.
The STOMPLOT list again, basically.
Yeah, pretty much. Pregnancy issues like placental abruption or amniotic fluid embolism are big ones. Liver disease, as we said. Maybe having had blood transfusions before. Certain meds.
It feels like situations where the body is already under immense stress.
That's a good way to put it. Situations with massive inflammation, widespread tissue damage, or, abnormal cells running rampant, like in cancer. These things disrupt that fine-tuned coagulation balance.
Okay, so let's get into the mechanism. The pathophysiology, what's actually happening step by step inside the blood vessels when DIC kicks off.
Right. It's this really complex interaction between the coagulation system, the clot formers, the fibrinolysis system, the clot breakers, and the endothelial cells, the cells lining the blood vessels. Normally, they're all in sync.
But in DIC?
In DIC, that underlying trigger, sepsis, trauma, whatever it is, causes this massive, uncontrolled activation of clotting factors.
Right.
This leads to widespread formation of tiny clots, microthrombi, all through the small blood vessels, like a sudden system-wide traffic jam.
So initially, it's all about clotting. Too much clotting.
Yes, but here's the twist. This massive clotting uses up the body's supply of clotting factors and platelets. They get consumed.
Ah, like using up all your ingredients.
Exactly. So when the body actually needs to form a clot properly, say to stop bleeding from a cut or an IV site, it can't. There's nothing left. This leads to the bleeding tendency.
So the clotting causes the bleeding.
In a way, yes. It's consumption coagulopathy. And at the same time, the fibrinolysis system gets activated to try and break down all those newly formed microthrombi.
Oh, eh?
But it goes into overdrive, too, and starts breaking down not just the unwanted clots, but also any necessary stabilizing clots the body might have formed, which, makes the bleeding even worse.
Wow, so it really is chaos.
Yeah.
Clotting and bleeding happening at the same time, driven by the same initial problem.
Precisely. Both thrombosis and hemorrhage simultaneously, due to this out-of-control activation and then exhaustion of the system. That's why it's so dangerous.
Given that complexity, I imagine other conditions might look similar. What else needs to be on the radar when thinking about DIC? What are the main differential diagnoses?
Yeah, good point. Accurate diagnosis is key. The notes mention a few important ones to consider. TTP, thrombotic, thrombocytopenic purpura,
Okay.
and HUS hemolytic uremic syndrome.
Sure.
These also involve microthrombi and low platelets, but the underlying cause, the mechanism, is different.
Right.
A specific type of leukemia, acute promyelocytic leukemia, or APL, can present very similarly with clotting issues.
APL.
Certain viruses, like hemorrhagic fever viruses, can cause both bleeding and clotting problems.
Mm-hmm.
And then, of course, you have to think about other more general bleeding or clotting disorders. It really comes down to looking at the whole clinical picture and the specific pattern of the lab tests.
So careful evaluation of context and those blood results is critical. Speaking of which, how common is DIC? Do we know much about its frequency, say, here in the UK?
Exact numbers for the UK specifically are a bit limited, as the notes point out. It's not always tracked as a primary diagnosis because...
It's always secondary.
Right. But we definitely know it's common in critical care settings. You see it quite often with patients who have severe sepsis, major trauma, certain cancers.
It's prevalent in the sickest patients.
Yes. And interestingly, there aren't really strong predispositions based on age, sex, or race. Anyone who develops a severe enough triggering condition could potentially get DIC.
Okay, so let's talk about how it looks clinically. If someone has DIC, what signs and symptoms might you actually see at the bedside?
It can vary quite a bit, depending on the cause and whether it's acute coming on fast or more subacute or chronic developing slowly.
Okay.
But common things you look for are signs of abnormal bleeding. That could be easy bruising, lots of petechia, those tiny pinprick bruises,
Right.
oozing from IV lines, catheters, wounds, or even from the gums or nose.
So bleeding is a major feature.
Often, yes. Also, signs of organ dysfunction. That's from the microthrombi blocking blood flow. So you might see kidney problems, confusion, suggesting brain involvement, breathing difficulties.
Due to clots blocking tiny vessels in those organs.
Exactly. And of course, you'll likely see signs of whatever triggered the DIC in the first place, fever and sepsis, signs of injury and trauma, etc.
And the notes distinguish between acute and the more chronic forms.
Yes. Acute DIC is often really dramatic. The classic textbook sign is bleeding from 3 or more unrelated sites at the same time.
3 sites? Wow.
Yeah, like bleeding from an IV site, blood in the urine, and coughing up blood. Patients might be confused, feverish, obviously hemorrhaging. You might see signs of ARDS, severe respiratory distress.
Right.
Skin signs can be prominent too in acute DIC widespread petechiae, larger purple patches called purpura, sometimes even blood-filled blisters, hemorrhagic bullae.
Sounds quite alarming.
It is. In severe cases, you can get acral cyanosis, blue fingers, and toes skin necrosis, which is tissue death, actual thrombosis or larger clots forming, leading to infarction or even gangrene.
A very serious picture. And the subacute or chronic form, how does that differ?
That tends to be less about the dramatic bleeding and more about the thrombotic side. So you might see more signs of clots forming, like a deep vein thrombosis, DVT in the leg, or a pulmonary embolism, PE, a clot in the lungs. The presentation can be subtler sometimes.
All right. So if you suspect DIC based on these clinical signs, What tests do you order to confirm it? What are the key lab findings?
Okay, several key blood tests are crucial. First, a complete blood count, or CBC. You're looking closely at the platelet count. It's typically low, especially in acute sepsis-driven DIC because they're getting used up making all those clots.
Low platelets, got it.
Then the coagulation profile. This includes the prothrombin time, PT, and the activated partial thromboplastin time, APTT. Both of these are usually prolonged, longer than normal, again, because the clotting factors are being consumed.
TT and APTT prolonged.
Fibrinogen levels are also important. Fibrinogen is what actually forms the clot mesh. It's often low because it's being used up, though sometimes early on or in chronic DIC, it can be normal or even high as an acute phase reactant.
Okay, so fibrinogen usually low, but maybe not always.
Exactly. And then a really key test is the D-dimer. D-dimer is a fragment produced when fibrin clots are broken down by plasmin.
Right, the clot breakdown product.
Yes. And because you have widespread clotting and widespread clot breakdown happening in DIC, the D-dimer level is usually significantly elevated. Very high.
High D-dimer, that seems quite specific.
It's a very sensitive marker, yeah. You might also do imaging, like CTs or ultrasounds, but that's usually to look for the underlying cause or complications like big clots, not really to diagnose the DIC itself.
Any other lab findings mentioned?
Sometimes you might see elevated levels of something called soluble fibrin or reduced levels of natural anticoagulants like antithrombin and protein C as they also get consumed. But the core ones are platelets, PTTT, fibrinogen, and D-dimer.
And I saw mention of a scoring system, the IST score.
Yes, the ISTH developed a scoring system to help diagnose overt DIC, basically, clinically significant DIC. It gives points based on how low the platelets are, how high the fibrin markers like D-dimer are, how prolonged the PT is, and how low the fibrinogen is.
So it combines those key tests.
Exactly. You add up the points. For example, platelets below 50 get 2 points, below 100 gets 1 point. Strong D-dimer elevation gets 3 points, moderate gets 2. PT prolonged by more than 6 seconds gets 2 points. Fibrinogen below 1 GL gets 1 point.
And there's a cutoff score.
Yeah, a score of 5 or more is generally considered consistent with overt DIC. Less than 5 suggests it's less likely, or maybe non-overt, and you might repeat the test later if you're still suspicious. It's a useful tool to standardize things.
That does sound helpful. The notes also had a table comparing DIC lab patterns to, say, warfarin or heparin effects.
Ah, yeah, that's useful for revision. Helps contrast how warfarin mainly hits PT, heparin mainly hits APT, aspirin affects platelets differently, whereas DIC messes up multiple parameters, low platelets, high PT, high APTT, high D-dimers. Good for comparison.
Yeah. Definitely a good memory aid. Okay, so you've diagnosed DIC using the clinical picture and these tests. How do you manage it? What's the approach?
The absolute #1 priority, the cornerstone of management, is treat the underlying cause.
Right, find the trigger and fix it.
Exactly. If it's sepsis, give antibiotics and support. If it's trauma, manage the injuries. If it's a malignancy, start appropriate treatment. Without fixing the trigger, the DIC will likely persist or recur.
Makes sense. What about supportive care for the DIC itself?
Supportive care is crucial. This often involves things like fluid resuscitation to keep blood pressure up and perfuse the organs, and importantly, blood product transfusions to replace what's being consumed.
Like platelets and clotting factors?
Yes. If the patient is bleeding significantly or needs surgery, you typically transfuse platelets to get the count up. You might give plasma, like fresh frozen plasma, FFP, to replace multiple clotting factors if the PT and APTT are very prolonged and there's bleeding.
FFP for factor replacement.
Right. If giving lots of FFP volume is a concern, maybe in heart failure, you might use specific factor concentrates instead. And if the fibrinogen level is critically low, if they're below 1 or 1.5 GL, especially with bleeding, you'd give fibrinogen concentrate or cryoprecipitate, which is rich in fibrinogen.
So replacing the specific components that are missing and needed.
Precisely. Tailoring it to the lab results and the clinical situation, primarily bleeding versus primarily clotting.
What about using anticoagulants like heparin? Seems counterintuitive if they're bleeding.
It does, but heparin is sometimes considered, mainly in cases where thrombosis clotting is the dominant feature, maybe chronic DIC related to cancer, or sometimes prophylactically in critically ill patients who aren't bleeding but are at high risk of clots. It's used very cautiously, though.
Okay. And what about drugs that stop clot breakdown, the antifibrinolytics?
Generally, those are avoided in DIC because blocking fibrinolysis might worsen the microthromby problem. There might be very rare, specific situations with extreme bleeding thought to be due to primary hyperfibrinolysis, where something like tranexamic acid is considered. but usually, no.
So mainstays are treat the cause, support with fluids and blood products targeted at the deficit.
That's the core strategy, yes.
What's the outlook then? What's the prognosis for someone with DIC?
It really depends on what triggered it, how severe the DIC is, how much organ damage has occurred, and critically, how quickly treatment for both the underlying cause and the DIC is started.
So lots of variables.
Absolutely. DIC itself can definitely be life-threatening, especially acute DIC, because of the risk of rapid organ failure from clots or catastrophic bleeding.
Right.
We know that mortality rates are significantly higher for patients with sepsis or severe trauma if they also develop DIC.
That makes sense.
Even if patients survive, there can be long-term consequences like residual organ damage, kidney problems, for example, or maybe limb ischemia if clots cause tissue death.
But recovery is possible.
Oh, yes, definitely. With prompt, appropriate treatment of the underlying condition and good supportive care for the DIC, many patients do recover well. Their overall health and other medical problems also play a role, of course.
Okay. And just to round things off, what are the main complications we should be aware of that stem directly from DIC?
Well, they really follow from the pathophysiology we discussed. The big ones are organ dysfunction or outright failure due to those microthrombi cutting off blood supply. Kidneys, lungs, brain, liver are often affected.
Okay, organ damage from clots.
And then the flip side, excessive bleeding, leading to hemorrhage, potentially into vital organs, or just significant blood loss.
Bleeding from factor consumption.
Exactly. You can also get recurrent or persistent DIC if the underlying trigger isn't fully controlled. And then there are the potential long-term complications related to the organ damage or the initiating illness itself.
So it really drives home how complex and dangerous this condition is.
Yeah.
A real double-edged sword stemming from that disturbed balance.
Absolutely.
I think the key takeaway for you listening is that DIC is the serious secondary problem. It's not a disease in itself. It's driven by that chaotic mix of clotting and bleeding, and sorting out the underlying cause is absolutely vital.
Precisely. Understanding all those pieces, the definition, triggers, how it works physiologically, how it presents, the tests, the management, it's all crucial for dealing with it effectively when you encounter it.
Definitely. Well, a huge thank you for walking us through that complex topic. It's given us a lot to think about. And for you, here's something to ponder. Given that so many different serious conditions can trigger DIC, what do you think are the biggest practical challenges in spotting it early and managing it effectively across different hospital settings? Something to mull over.
Good question.
If you want to consolidate this or explore other topics, remember to check out PassTheMSRA.com and FreeMSRA.com for revision notes and resources.
Great resources there.
Thanks again for joining us on the Deep Dive. Until next time, keep exploring.